Okay. Okay. So I'm starting, right? Dr. Hira, can I start?
Yes, Dr. Manju, you can start.
Okay, done. So, hello, good evening, everyone. So, I'm Dr. Manjula. So, I'll be your mentor, and I'll be discussing about a few cases with you in these 3 days. So, I took one case from each station, and then I'll be discussing daily 2 cases. And just this is a little different from. I feel this is a little different because I want to explain to you how to present, taking care of all the important points. So please mute the mic, somebody. So I want to tell you how to present because I feel asking you to present. You don't know how to present. That's why you're coming to us. You want to know how to present and you want to pass this exam. So that is the reason why you are joining the study groups. And if I ask you to present without knowing how to present, you will be presenting and then we will give the feedback and we will say you have committed this mistake, you have committed this mistake, this should not be this should not be that. So that sometimes will reduce your confidence. You may become morally low. And also, as people are presenting, when they are asked to present, when they start presenting, you will not listen to them because you will be under tension. You will be thinking how you are going to present. You will not listen to them. You will not listen to the feedback. Nothing you are going to listen. So I feel that is, I will tell you how to present. Then you have to practice. You'll be practicing. That means you'll present this case in front of the other mentor. So that is Dr. Padma. So she is a mentor who will take your he will give you the feedback. You will present to her and she will give you the feedback. So this is our way of teaching, and it is an audio presentation. So whenever you want in your clinic or anywhere, you can just play it. Slides, going through slides, it is not going to do much help because you want to listen to the voice, how the station goes. It is a Breaking Bad news station, then your volume of the voice should be low according to the situation. So that with this short introduction, I want to say something. We'll start with one case. From today, I will be discussing about 2 cases. One is pregnancy of unknown location. Here, intentionally, I have put PUL. Never, because just I want to say, never use any abbreviation. PUL is not supposed to be used. You should say pregnancy of unknown location. This is I have to intentionally kept it because I want to say that we should not write PUL. We should not say any no abbreviation is I mean they don't like abbreviation. Even the to the explain when you explain to the patient or when you explain to the colleagues or anyone or examiner, we always say the full form. So now, so pregnancy of unknown location. This is one case, one station from early pregnancy module. So just a few words about the early pregnancy. I will tell about early pregnancy, about pregnancy of unknown location. Then I will present another case, an abnormal baby. So before that, let me tell you about the pregnancy of unknown location. So in a pregnancy of unknown location, and there are see, you should take the information gathering. I already told you yesterday that information gathering should be crisp and it should be to the point. Targeted history. Don't say and ask irrelevant things. So what is this case? It is an early pregnancy. And when you see the scenario, you know it is, to some extent you will know from the findings and all, that it is an unknown location. So you will know what to ask. She may come with pain, she may come with bleeding. So you have to take a good history after introducing yourself, after making the agenda, which I'm going to say. You will start asking her about, to ask her open question. So she will say why she has come, the bleeding or this. So any bleeding in early pregnancy, common symptoms you should ask: bleeding, pain, pain in the tummy you can say tummy, then pain, bleeding, giddiness, fainting, because it can be ectopic. There can be internal bleeding. So which is related to pregnancy conditions. So pain, bleeding, and giddiness, shoulder tip pain, some discharge, or if it is if because it's early pregnancy, some discharge can be there, and urinary symptoms, bowel symptoms, which are all common things which are there with which they can present. So some urinary infection. So this is related to that you take. And history, then history, history, you have to take the complaints, that is history of present illness, the obstetric history, the present pregnancy, the previous pregnancy, past obstetric history, the present pregnancy. You have to say, take about the last menstrual period. What is the last menstrual period? And how are your periods, regular or not? Because irregular cycles, it is different. Again, the gestation age may not be correlating. So last menstrual period, and you have to ask whether it's a planned pregnancy or it is an unplanned pregnancy. So after taking the presenting complaints, that is bleeding, all which I told you, then you have to ask about the present pregnancy detail. This is all information gathering. Then with a planned pregnancy, unplanned pregnancy, if it is a planned pregnancy, then what you have to ask is different. If it is unplanned pregnancy, what you are supposed to ask is different. Now let me tell you, if it is a planned pregnancy, you say if it is a planned pregnancy, and if the pregnancy is a healthy pregnancy, if you think that the baby is alive and healthy pregnancy, you can say congratulations. But if it is an unhealthy pregnancy, that is miscarriage or pregnancy of unknown location, so you don't say any congratulations. Now, then you ask if it is a planned pregnancy, any issues in this pregnancy? Do you have any issues in this pregnancy, like bleeding or any bowel symptom, bladder symptoms, or anything, vomiting, excessive vomiting? And then after that, which is related to the pregnancy, then you say, have you done your booking blood test and have you done the dating scan? So these are the relevant things which you should ask in the planned pregnancy. Suppose she says, no doctor, this is unplanned pregnancy. In that case, you have to ask, that means she has, have you used any contraceptives? Because contraceptive failure can lead to pregnancy, and it is an unplanned pregnancy. Sometimes they don't want the pregnancy also. So you ask about the, if it is unplanned, were you using any contraceptives? Because of the condom, rupture of condom or something can happen, or missing the pills. So in that case, if it is unplanned pregnancy, what are your thoughts about it? Would you like to, then she will say continue the pregnancy, or they want to go for termination of pregnancy. Then when they say that it is an unplanned pregnancy, any contraceptive failure, then you say, next I will be referring you to the contraception clinic, so that they will advise you about the contraceptive methods. So this is about the present pregnancy. Now, previous pregnancy, past pregnancies, obstetric history. About the previous pregnancies, you ask, have you been pregnant before? Then she will say, yes, doctor, or no, doctor. So yes means, can you tell me about it? Then whether it is a term pregnancy or preterm or what, miscarriage, whatever. Can you tell me about it? Can you give me the details? So she will say, if it is a term pregnancy, then you ask, what is the how did she deliver? Whether it's a normal delivery or it is a cesarean section or an instrumental delivery. How is the baby? Where the baby is doing, what was the birth weight of the baby? How was the baby at the time of delivery? And how is the baby doing now? Then you have to ask about her recovery. Always her recovery. Then you say, can I see your notes? Always see the notes of the previous pregnancy. This is only about the pregnancy. Pregnancy I'm telling you, early pregnancy. So then,
Dr.
what about your future plans? Would you like to have a baby in future? Because it could be an ectopic pregnancy where the tube we have to remove the tube, and she may not be having the other tube. So that is why we have to ask about the fertility option. What are the future plans? Then after that, after past obstetric history, then we will go for the gynec history. In the gynec history, always you ask, suppose you have already asked a last menstrual period, don't repeat again. Otherwise, if you have forgotten that time, now you ask LMP. What is your last period? When was your last period? Then, if she is less than 25, only 4 things you have to ask in the gynec history. Periods, whether if you have not asked before, periods, LMP, and whether periods are regular, she has used any contraception. And what about the smear? If she is less than 25, don't ask. If it is more than 25 years, because we don't do smear in before 25. Be careful with the age when you ask the smear. So then you ask if she has a previous pregnancy, already have taken the history. Suppose she says the previous pregnancy had termination, she had undergone termination of pregnancy that time. So then that means repeatedly she is going for termination of pregnancy. Then you have to ask about the sexually shared infection. Anytime, have you had any time, you or your partner, any sexually shared infection? For like have you had any pain in the tummy, discharge, fever? So these are the 3 symptoms of this sexually shared infection. That means fever, abdominal pain, tummy pain, and discharge, foul smelling discharge. So she will say, then that is about the gynec history. Only these things. Then medical history, coming to the now medical history. Medical history, are you on any medication? Are you taking any medication? If suppose she's taking, what medication are you taking? Can you tell me what the medications are you taking? Sometimes they can be early pregnancy with medical condition. They can give a scenario with a medical condition. For example, any molar pregnancy with thrombocytopenia, they can give, or any pregnancy miscarriage with asthma, which is related, because suppose in that case you have to give carboprostol, misoprostol, which is contraindicated. So they will give the medical, so sometimes they'll give medical conditions, associated condition. If suppose the patient case scenario says she's an asthmatic or she has migraine or anything, you ask, are you taking any medication? What medication? Are you seeing regularly your doctor? How is the control? When did you see the doctor last? And does your doctor know that you're pregnant? So these are the things which you should keep in your mind when you take the history, medical history. Then allergies. You ask allergies in the medical history. Allergy is a patient safety point. Very important patient safety point. So allergy. Uh, so yeah. Yes. So, can you tell what allergy are you having? Any known allergies? Then, allergy to drugs or food. Then, what that is important. Can you tell me your blood group? And do you have a, and what is the blood group, and do you have any reservation to accept blood in case it is required? Then, going to the surgery. Surgery is also important. So, have you undergone any surgery operations in the past? Operation surgeries also they will understand in the past. Okay. Then, what type of surgery and how was your recovery? Anything, any surgery, any delivery, recovery, you have to ask about the recovery, any injury, recovery. Then, any family is coming to the now after surgical family history. Any family history of any concern, just you say, do you have hypertension? Do you have diabetes? No need to ask so many questions. Just you say, do you have any family history of any concern? Except suppose this patient has any abnormal baby, suppose in the scan report shows some abnormality in the baby, that time you can ask, do you have any family history of any abnormal babies in the family? Or if the history says that she has any DVT, so in that case whether she has got any abnormal, in that case you can ask whether families of any coagulation disorders, thrombophilias. But otherwise you can just say, yeah, straightforward case, any families of any concern. Then coming to the social history, can you can you ask whether you take smoke? Do you smoke? Don't say pardon me for asking, because smoking and alcohol no need to ask pardon me. You can just ask because it's a normal thing. Do you smoke? Take alcohol? In that case, suppose they say yes, then you say how much is quantity, how much you take, and alcohol also, what is the quantity, how much you take. And then then now for the drugs, it is you say pardon me for asking, because drugs is not very common, something which is a taboo. So can you pardon me for asking, can I ask you, do you take any recreational drugs or drugs for fun? Okay, these are the things, because they can affect your the baby, this pregnancy. That is why. Then can I, if the BMI, can I ask you your BMI? Some people that you can say BMI also, they will know, or height weight ratio. Can I ask you, do you have any idea about it? Suppose all these things, this BMI is given in the case scenario, don't ask. Then, what do you do for living? Because we want to know what type of work she's doing, whether she's working or just. Then, how is the support at home? Suppose she's used, her name is written as Miss. Suppose Miss Lily or something. Then you say partner. Suppose she's written Mrs. Lily. Then you say your husband. So that way you be careful. So your partner or your husband. See what she is actually, Miss or what is her name, or Mrs. Then, because we want to know how is the support from him, we want to know whether there is any domestic violence. That is why support. Then, sometimes they will have mental problems, sometimes depression or so, especially pregnancy. So, pregnancy, there can be some depression, or there can be history of depression also. So, you say in the past few weeks, were you down and depressed and low moods, down or depressed? So, that way your mental health you have to ask. Now, coming to this is about the history. Now you have completed the history, then you should ask, would you like to add anything? Sometimes you must have missed asking some question, or she must have missed, she want to say. So would you like to add anything? One important word you have to say. This comes 2 times. Yesterday also I told. One is now and one is at the closure of the station. So after that, coming to the examination. So every case no need to examine. If the examinations are findings are given, then no need to examine. Even if the examination findings are not given, then also sometimes examination is not important. For example, if the patient comes with asymptom, there's no symptoms, nothing, no bleeding, nothing, she comes with a scan report, then no need to do any examination. But if she comes with a bleeding or discharge, then you have to do examination. So when you do the examination, you say why you are doing, why you have to give the reason for examining a patient. So you say, can I examine you? Always take permission. Permission, that is consent. That's a patient safety point. So can I examine you, your tummy, and also your, I would like to do internally also, I would like to this down below you can say, and I would like to see the neck of the womb, to see whether there is any, if she complains of bleeding, to see whether there is any bleeding, where bleeding is coming from, and if there is any discharge, to see whether infection is there. So whatever the symptoms she complains of, you tell. So why you want to do the examination, you have to tell her. Then consent, that is consent. Then you say, this is an internal examination, I will examine you in the presence of chaperone. Chaperone is a patient safety point. Don't ever forget chaperone, because if you say without saying that word, you will it's not a good thing to do. Without chaperone, don't examine. So tell her, in the presence of chaperone, can I examine you? My nurse will check your blood pressure and pulse rate. She will check, and I will examine your tummy and down below to see the neck of the womb, whether from where the bleeding is coming or from where the discharge is coming, if she complains. So this way you have to go with the pregnancy this information gathering. Then coming to the after examination, now you have to come to the discussion. Yeah, then see the investigations. Sometimes they will provide the investigations along with the case station. So see the stay where what investigations are given. Remember them. Even after entering the room also, cubicle also, you can see the papers will be there on the table. You can see them, or you can write down the investigations given outside. You can write down the prescription pad which is given. You can write down, and what is not given, you can ask her to do. Now, investigations are in your hand. Check the name on the investigation paper. Check the name, age, NHS number, whether that is matching with the case scenario or not. Whether it is matching with the case scenario with the patient's name and the investigations, that name of the patient, same or not. Sometimes they intentionally keep the different name. So that is patient safety point. So you are not explaining, you are explaining correct result to the correct patient. So investigations are over. Now, you already asked, would you like to add anything? Now you have to explain her situation. By this time, you know what is the condition, what is her condition, and you will know how you have to explain to her. You should keep one or one. If it is straightforward case, it is one diagnosis. But if it's not straightforward case, you may have to tell her 2 diagnoses or 3 diagnoses. Differential diagnosis is also important if it is not a straightforward case. Then you keep in your mind. Now you have to start. If you remember her name, you take the name. So, if you don't remember, don't say wrong name. So you say, Lily, now let me explain to you. You have to explain in simple language, in not medical terms, in her own what she understands. See, let me tell you, and you have to explain the results. Now I'm going to tell you about this case, so when you will understand properly. Explain her about the condition, what condition she has. Explain the investigation first, investigate blood reports and scan report and whatever you have, and then draw diagram. Draw a diagram. Almost every case you have to draw a diagram. Explain to her, this is this, and so this is your case. So then you say, suppose she comes with a scan report, ask her, do you have any idea about the scan report? Always check her understanding, whether she knows, whether somebody has told her already or she doesn't know. Then after explaining to a diagram and then explaining to her the situation, give her management, investigations. What investigations you are supposed to do and what is the management options. Management always don't give one option. So you have to give her 2 or 3 options. Usually there will be 2 or 3 options. So give her options. Each option, give her risk and benefits. What is the risk and what is the benefit of this each case? Then, see, these are the options we have, and it's up to you to decide. Whatever decision you make, it will be respected. So this way you have to say. Always give patient full freedom, autonomy. Don't force your opinion on her. No, this is the treatment, don't say. Because she is mentally not abnormal. She is sound. So she knows what it is. Explain to her and don't force. So then after the management, you say, these are the options. You can take your time. If it is not very emergency, you can discuss with your partner or with your husband or family members, and we'll give an appointment with our consultant. Now, every station you are the trainee, you are not the consultant. So you don't take any decision yourself. So you say, I'll inform my consultant. Now, after applied clinical knowledge, now you're going to close it. You're going to close the station. So you say, now, do you have any other concerns? This is the second time you have to ask her. Do you have any other concern? No, doctor, or yes, doctor, she will say. Whatever she says, listen to that. Now, then you say, okay, I will document whatever we have discussed, because documentation is very important. Yesterday also I stressed, I will document whatever we have written, though you're not documenting, but you have to use that word. And in a clinical practice, you're going to do that. Documentation is very important to save you from the medical legal cases. And also it is our duty to be honest, and we have to document. So it's a part of our clinical practice. So document, I'm going to document whatever we have discussed, and I will give an information leaflet, because about what we have discussed. So whatever the case she has, you are going to give that particular information leaflet. She will read it. Then she will have a broader idea. So I'll give an information leaflet. So this is the second point. Total 6 points will be there at the closure. So you're going to document. You're going to give the information leaflet. And I'm going to give an appointment with my consultant. The next appointment will be with my consultant or any physician. Suppose she's asthmatic, you're going to give an appointment with the physician, or diabetes specialist, anything. Then now scan means scan appointment. So appointments. Then fourth one is support group. For everything there will be a support group, because the similar type of case many people will be having. So they have that is a support group. So when she discusses with this support group, people who are having similar condition, she will think that people are there like her. So it will support her. So always connect her to support group. And if she is referred by a GP, or I'll write back to GP. I'll write back to GP, because involve the colleagues. It is your duty to inform him, but with your consent, with your permission, I'll write back to GP. Always take her permission, because you have no right to inform GP without her permission. Last is, sixth point is 24-hour contact number. Some cases you need to give 24-hour contact number. So that means if she develop any bleeding or anything, to come. So this is the way you have to do the closure. Now, thank you for your time. Always thank the patient, and then. Now, we'll move on to the first topic, that is pregnancy of unknown location. That is, there are some topics in early pregnancy which you are supposed to familiarize and practice. One is molar pregnancy, which is very important. It can come as a simulated patient task where role player is involved. It can come as a structured discussion. Anything can come as a structured discussion. Anything can come as a simulated patient task. And so simulated patient task is with the communication with the role player. Structured discussion can be with the consultant, can be with your junior colleague, or it can be with the some other officer, senior house officer, some colleague. Now, the other topic which is important is ectopic pregnancy, which is very important. Ectopic pregnancy can come for the surgical management, can come for medical management, can come for expected management. Read thoroughly ectopic pregnancy. Third thing, the other ectopics, very rarely they are asked. Cervical, scar, them. So ectopic pregnancy, tubal is what commonly asked. So that is the second thing. Third case, what you can get is miscarriages. Miscarriages can be threatened. It can be recurrent miscarriage. Recurrent miscarriage is very important. And it can be inevitable. So like cervical incompetence can be there. Such things. So, and infective, septic abortion. Septic. So involving the sepsis. So then, third thing is, they may come with a histopathological report. After miscarriage, the products will be sent. They'll come with that histopathological report. So that also can come. And then nausea, vomiting of pregnancy. So these are the expected stations which can come in the exam. So you be thorough with the GTG, Green Top Guidelines, all the topics. Any topic can come. Any topic can come as a structured discussion, as a simulated patient task. And talks, recent talks. So anything which is clinically relevant, not rare things, which is commonly come across in your clinic, those cases you have to go through. And nice guideline. And see some audios also, videos also, RCOG videos. Now, we'll move on to the first case. So with this introduction, I will move on to the first case, that is pregnancy of unknown location. So now, Can you move on to the slide, please? Next slide. So there is a case scenario. So we'll move on to the next slide, please. Yes, thank you. So this is a case scenario. This is a simulated patient task. It is always C. At the top of the case, it will be written simulated patient task or structured discussion. Be very careful. That's one thing. Second thing, pregnancy assessment unit, where you are, which domain, that means which place, early pregnancy unit or antenatal or postpartum, whatever it is. So you have to see that. Don't say one thing for the other. Then patient name, Miss or Mrs. What is her age? Write down on the prescription, on the your pad, letter pad given. Symptoms, what are the symptoms given with the case? She comes with light bleeding, whatever. And then some investigations will be given. See all the investigations, and if possible, you note down or remember. Now, this is a case which I am going to read out. You're an ST5. Always you're an ST5. Because when you're appearing for part 3, you're ST5. You're an ST5 in early pregnancy assessment unit. A 24-year-old Miss Maria John comes to you with slight bleeding and pregnancy test positive. Her observations are stable. Then it is an unplanned pregnancy. Her blood group is A positive. Her beta HCG is 1100 units and hemoglobin is 13 gram per liter, and then BMI is 27. So moving on to the next slide, please. So next slide, please. So then whatever findings are given, don't repeat. Remember them. So BMI is normal, hemoglobin is normal, she's stable, beta HCG is positive, A positive, she is not negative. Now, what is the examiner, what they want you? See, whatever they asked you, you have to see that carefully. Obtain targeted history related to the symptoms given. Don't ask unnecessary things. So whatever they ask, you do that. And so targeted history you have to take. That is important. You'll get points. Explain the results. So what results are given here? Hemoglobin, beta HCG, and these are given. So you have to explain those two things. And she will have concerns. Whatever concern she has, you have to answer her concern. Then you have to give her management, safe management. Now, move on to next slide, please. So, next slide, please. Yes, now the scan findings are given. Sometimes they'll give the image also. Scan image also will be there. So, the scan finding shows LMP is given. 5 weeks, valid consent. Without consent, we won't do the scan. Uterus is antevoted, normal size. Endometrium is 12 millimeter. No intrauterine gestation sac. Next slide, please. So, there is no sac seen. So, now, right ovary, normal, corpus luteum. It is a normal thing, but patient may not know. She will be concerned. So, you have to explain to her. Left ovary is normal. Minimal fluid in pouch of Douglas. Impression, pregnancy of unknown location. Because we are not able to see pregnancy inside the uterus and outside the uterus. Ectopic pregnancy cannot be ruled out. So, next slide, please, if it is there. So, then, now, so this is the case scenario. So, here, now I will tell you how to present this case. Okay. Now, so let me tell you. Hello. So, I'm starting the case now. Station, how you have to present. Hello. You are going to introduce. Hello, I'm so-and-so. I'm one of the doctors in early pregnancy assessment unit. So you are introducing yourself, and I am a registrar. You can say I'm a registrar from early pregnancy assessment unit. May I confirm your name and age, please? It is very important safety point. May I confirm your name and age, please? So she will say, I'm Miss Maria John, doctor. I'm 24-year-old. So then how may I address you? Then she will say, Maria, you can call me Dr. Maria. You can call me Maria. Okay, now that is introduction. Now we are coming to the agenda. See, Maria, I can see from your notes. If it is a GP letter, you can say, I can see from your GP letter. If he is referred by GP. Or if she just comes with the complaints, you say, I can see from your notes that you are pregnant at 5 weeks. And you had a scan done today. You had a scan done today, and you are here to discuss about the scan findings, scan report. And you have some concerns also. So, am I correct? So, just you can confirm, am I correct? Because same thing is given the case scenario. Whatever is given the case scenario, you are asking her. So, so she will say, yes, doctor. So, same thing, the gestation age, then bleeding, minimal bleeding, scan report. So, Now, I will address all your concerns. Maria, I'll address all your concerns. But before that, can I get a few details from you? Before that, to make a management plan? Okay, don't use long sentences. It will take your time. It will, short sentences only and simple language. Okay, can you get more information from you? Before I explain to you your condition? Okay. Now, because you know it is early pregnancy and she comes with a minimal bleeding, can you tell me more about you? Is the important thing. Don't ask, do you have bleeding? Do you have pain? Do you have this? But it is always better to ask her, can you tell me more about you? It is an open question. So she will tell you what she has. So, can you tell, always open question is better. So, can you tell me more about you? Then she will say, Doctor, I have bleeding. If suppose she has bleeding, or then you have to ask about bleeding. What all things you should ask? Can you tell me since when? Since when? What duration? Since when? And how is the bleeding? Is it slight, minimal, or moderate, or excessive? Do you pass clots? So, about the amount. So, since when and amount. Then, are you passing any clots? Any vesicles? Can she sometimes early pregnancy? No, sometimes you can ask. So, bleeding is over. Now, next thing you should ask is pain. Do you have any pain in the tummy? She herself will say, or if she doesn't say, then you can say, do you have pain in the tummy? Or any shoulder tip pain? Because now you don't know what is the, you know it is a pregnancy of unknown location. It can turn out to be ectopic also. So you have to ask, do you have any pain in the tummy? Or do you have any shoulder tip pain? How about, do you have any fainting attacks? Or she herself can say, Doctor, I feel sometimes fainting and giddy also. Sometimes she will say. Then, feeling unwell. Do you have any problem with the waterworks? Because bladder is can have, pressure of the uterus, pregnant uterus on the bladder. She can have recurrent urinary infection. She can have frequency, all those things. So, or any bleeding in the pouch or Douglas, or any can have pressure on the rectum also. So, you can. Do you have any problem with the bowel or waterworks? These things. So, any issues with the bowel, any issue with the waterworks. So, this is about the history of present illness. So, you are asking her bleeding and relevant things only, not too many things. Bleeding, pain, and feeling giddiness, unwell, and any bowel bladder disturbances. Now, that is about the history of present illness. That's all. Now, coming to the present pregnancy, you have to ask about this present pregnancy, details about this present pregnancy. Is it your first pregnancy? Ask her, is it your first pregnancy? Because then you shall know, doctor, it is second pregnancy or third pregnancy. Then you have to ask about those pregnancies in past obstetric history. So she will say, no, yes, doctor, or no, doctor. Then, any pregnancy, ask, is it planned pregnancy? Or she will say yes. Then if it's planned pregnancy, you have to ask, how is the pregnancy so far? That means whether she has any bleeding or any excessive vomiting, what common problems they have. So that, how is the pregnancy so far? Then that is one thing, if it is a planned pregnancy. The second thing, have you done your booking blood test? Second thing. Third thing, is the scan done today? Is the first scan, or have you done any scan before? So any pregnancy, in not only this case, you have to ask these things. So then booking blood test, scan. Now, if it is an unplanned pregnancy, suppose she said, no doctor, this is unplanned. I don't want this pregnant. Then you say, have you used any contraceptives? And if she says yes, then you say, after this pregnancy, we will refer you to the contraception clinic. Then if she say, then what are your thoughts about this pregnancy? Then coming to the, so after that, so this is the present pregnancy over now. Now coming to the previous pregnancy, because she told you one or two pregnancies, she must have told. So you ask in this she had one termination of pregnancy. So sometimes they give the recall, they can change the situation. They can change. They it need not come exactly. So this patient had some termination of pregnancy before. So if she says any termination of pregnancy, anytime you ask three things. One is gestation age, what time you had this termination. Second thing, scan. Have you done a scan and heartbeat was seen? Whether heartbeat was seen and how was it managed? That is, whether it was managed expectant treatment, or they have given you medication, or they have given the surgery, some small surgery, cleaning of the womb. So what type of treatment, and how was your recovery. After every treatment, you have to ask recovery. So, okay. Now, that is about the previous miscarriages. So, coming to the previous normal delivery, suppose she had a baby, she has babies, then you say what type of delivery. If it is normal delivery, then how is the baby at the time of birth, what is the birth weight, and and how was the baby at the time of delivery, and but that means whether the baby had any problem and how is the baby doing now. Then how was your recovery. So she will say she had any complication or this or that. So both the thing, and you take the cesarean. Suppose it is a cesarean section or third degree, fourth degree tears. You take notes. Do you have the notes? So okay. Now then ask about the present. So previous pregnancy you have asked. In this case also you have to ask previous pregnancy. In this case she had one termination of pregnancy. What type of how many weeks were you at that time, and how was it managed? When the scan was done, when the heartbeat was seen, and how was it managed? She will tell you, because the similar case may not be there every time. So they will change. Examiner RCOG can change. So whatever the role player is told, she will tell you. Then after that, recovery is over. Now coming to the gynec history. I told you already, ask LMP if you have not, because it is given 5 weeks, no need to ask. But you can ask your previous cycles were regular. And if she is more than 25 years, she's 24 now. Remember, she's 24. Don't ask screening, cervical screening. Then, because she had termination of pregnancy, you ask her any infection. Sexually, have you had any, you or your partner, had any infection in the past, sexually shared infection like pain in the tummy, fever, and discharge? That's all. Now, coming to the medical history. Are you on any long-term medication? She will say yes or no. If it is yes, about the medical condition which I told you. Then, any allergies, and what is your blood group? Because we may have to do, blood group is very important safety point. And do you have any reservation to accept blood if need arises? Then, any history, have you undergone any surgeries in the past, any operations in the past in the tummy or down below? Operations on the tummy or vaginal area, pelvic area, not other things. But sometimes you can, she will tell spinal cord injury or something. But relevant history you ask. Then family history, medical is over, surgery is over, family history of any concern. Then do you smoke? Can you ask a few personal questions? Do you smoke? Take alcohol? And how about, pardon me for asking, do you take any recreational drugs? Then BMI, if it is given, I see that your BMI is 24. Just repeat, that's all. If it's not given, can you tell me what is your BMI? Then how is the support at home? In this case, how is the support at home? Is your partner supportive? Then how far you after support is over, how do you feel? Do you feel down or depressed anytime in the past 2 weeks? Not from olden days, just recent. Because in antenatal case, every antenatal checkup they will ask Woolies questions. That is, they will check her mental status. Then, how far do you stay from hospital? Because if it is an ectopic pregnancy, at present we don't know. From the scan report, we don't know. But it can turn out to be an ectopic anytime. So she can come with ruptured ectopic. So you say how far you stay from the hospital. That is a patient safety point. Because 20% of these pregnancy of unknown locations can become ectopic. So, history is over. Would you like to add anything? Or I told you already. Then, now because she came with minimal bleeding, you would say, I would like, can I examine you in the presence of chaperone? Can I examine you? I would like to, why you want to examine? My nurse will check your blood pressure, because now here, already stable, her observations are stable. So don't say, my nurse will take blood pressure and pulse rate. Don't say. Remember that your blood pressure and pulse rate, your observations are stable. I would like to, if you allow me, can I examine you in the presence of chaperone? I would like to see your tummy, and also down below, I want to see the neck of the womb, about the bleeding, from where the bleeding is coming and how much, and also any discharge. If she says any discharge, any discharge. So that's over. Now, so examination is over. Investigations are already given. So now you have to come to the applied clinical knowledge. So remember, if you remember her name, take her name. If you don't remember, don't take her name. Don't say wrong name. So Maria, now make her comfortable. Let me explain to you. Your observations are fine. Same thing you're repeating. Whatever investigations are there, you're supposed to explain to her. Your observations are fine. And in terms of your blood report, I have seen your blood reports. In terms of your blood reports and your scan report, I have confirmed your name, age, and NHS number, and they belong to you. Say one word for all the investigations. Don't say for blood and again for again name and NHS number. Don't say so many times. Once you say, I have seen your blood reports and the investigations which are attached here. I have confirmed your name, age, and NHS number, and they belong to you. Now, your blood report shows the blood strength is normal. Hemoglobin. Blood strength is hemoglobin. We usually, hemoglobin, they may not understand. You can say blood strength is what we use. Is normal. Your pregnancy hormone, beta HCG, they won't understand. Your blood pregnancy hormone is in the is 1100. Whatever is given, you say, and you say that means you're pregnant. That means you're pregnant. Then coming to the scan report, let me draw. Always draw. Draw and say. Let me draw the scan, and this is the womb, and this is the lining of the womb, and then usually pregnancy is seen in the womb here. You say in the lining of the womb, and now it is not seen. Here no pregnancy is seen, and outside also it is not seen. Pregnancy is not seen inside the womb, and pregnancy is not seen outside the womb also. Now that means you're pregnant. From the blood report, you're pregnant, but we are unable to locate the pregnancy. This condition is called pregnancy of unknown location. I'm sorry, bring down your tone because it is something not very pleasant. She is confused. I'm sorry to give you this type of information, uncertain information. You are giving uncertain information. That means it's not your fault, but it is written like that. So I'm sorry to give you this uncertain information. And also, let me tell you about other scan findings also. These are the two ovaries. Ovaries, they will understand. Ovaries, see, one ovary, that is this right ovary, this is the right ovary, and this is the left ovary. You say both. And a small fluid filled sac. For the cyst, we say fluid filled sac. We can say fluid filled sac is seen, and that is around 3 centimeters. So it is they have written normal corpus luteum. So it is an innocent cyst. It is an innocent cyst. It will disappear by itself because she doesn't know. If there is a cyst, she will get worried. She doesn't know whether it's innocent or not unless you tell her. So you say it is an innocent cyst. It will disappear. So that means you're reassuring her about the cyst. Now, in such a situation, so then, now what, doctor? You have told the scan finding. Then she will. Then just wait. Then don't continuously say and finish off the station. Say, now doctor, what should I do? What are you going to do for me? And I'm not pregnant. Then already you told she's pregnant, but she again get it out. Pregnancy is not seen. Then what is this condition, doctor? Anything she can ask. Then you say, I know, I can see your anxiety. I can understand. Don't say I can understand. Always never use that understand word in the station, any station. You say, I can see your anxiety. Let me explain to you. Let me explain to you. There are 3 possibilities. Now, there are 3 possibilities in your case. The first is, it could be an early pregnancy, very early pregnancy, where it will take time to appear in the scan. Normally, it is seen 3 weeks after the conception, after pregnancy, after you become pregnant. So normally it is in 3 weeks after the conception, but in here maybe it is too early. That's why we are not able to see. That could be one possibility. The second possibility could be it is maybe it is a miscarriage. It's in the process of miscarriage. It must have been a miscarriage, already miscarried. So many pregnancies actually will become pregnant and they miscarry. So it could be miscarriage, but still, then she may say, doctor, but still pregnancy test is positive. So even, but still, if she doesn't ask also, you say, the pregnancy, even if it is miscarriage, the pregnancy test can be positive for 1 or 2 weeks. After the miscarriage, it can be positive. We also come and see, no. So that is the second possibility. The other possibility, third possibility, you can just put 1, 2, 3 on the prescription pad which is given at the place where you're drawing and showing. There also you can put 1, 2, 3. Then the third possibility is which we are worried because there is a possibility that this pregnancy, it could be outside the womb. It can turn out to be a pregnancy outside the womb. It can be in the tube, outside the womb, anywhere. Though it is called ectopic pregnancy. This condition, we call it as ectopic pregnancy. And Because in this case, where pregnancy we are not able to locate now, 20% or 1 in 5 can turn to, always use simple numbers, 1 in 5 can turn into ectopic pregnancy. If you remember, you say the in this thing. If you don't remember, don't say wrong thing. Now, then she will say, now you have explained the condition, this diagnosis you have explained. Now she will say, doctor, I don't want this pregnancy, it is unplanned, I don't want this pregnancy, you just remove this pregnancy. So what you say, I can see, Maria, your anxiety, I know that you want to end up this pregnancy. We will help you to end up this pregnancy, but before that we need to confirm where the pregnancy is before that. So it can be inside the womb or it can be outside the womb. Then that time we can decide the how to remove the pregnancy. Now, as you don't have any pain, you're not having pain, and your observations are stable, we are not admitting you. We keep you in follow up. You need to come to us. Now, we need to repeat this pregnancy hormone test after 48 hours of the first test. So that you have to say. So if the first test is done today, that means you have to do it after 48 hours. If the first test is done yesterday, you have to do it tomorrow. So always be specific. 48 hours after the first test. So we will repeat the pregnancy hormone after 48 hours after the first test, and then we will decide about it. We will again discuss about the management depending upon the value. So the possibility. Can I explain to you further? Can I move on? Can I explain to you further? Or she herself will ask, doctor, then what is the management after that? What will you do for me? Or you can say, can I proceed? Can I explain to you? Then, yes, now you have to explain that she'll come with the second report. So now the second report, if the value shows significant increase, she may not understand 63% this or that, significant increase, or you can say simple word doubling. If it shows more than doubling, then it will be an pregnancy inside the womb, and we will do a scan in 1 or 2 weeks. Then we will confirm the pregnancy. At that time, we will discuss about the ending of your pregnancy, how to end up your pregnancy, because she wants pregnancy to be terminated. That time we will terminate the pregnancy. It can be medical. It can be. We will explain to you that time. It could be medical, giving some medicines, or it can be a small operation. Then second thing, suppose the blood hormone which we do, it will be falling. That means you are in the process of miscarriage. So no treatment will be required. In which pregnancy is not seen in the womb, hormone also is falling. So you are miscarried. So then we will do a pregnancy test, urine pregnancy test after 3 weeks, and confirm that it is a miscarriage. If that time it is, then no need to too much explain, because then if that time it is negative, that is over actually, that is the end of it. But if it is positive, it comes as positive, then you have, for your information, I am telling you, if it comes as positive after 3 weeks, you have to send her to the early pregnancy assessment unit to know where is the pregnancy. Then third possibility could be this pregnancy hormone can remain same, neither increasing, adequate increase, nor adequate decrease. Nothing it is there. It is almost, it may not be similar. It can neither, there is no proper increase, there is no proper decrease. So it will not fit into intrauterine pregnancy. It will not fit into miscarriage. So this condition, we call it as the possibility of pregnancy outside is there. That means it is called ectopic. So that could be the possibility. And in that case, we will do a scan. We will refer you to the early pregnancy assessment unit within 24 hours, and a scan will be done. Within 24 hours, a scan will be done, because it is important. So then as after scan is done, we will confirm that the pregnancy is outside, and depending upon that, we will discuss the management, because we will not give medicines for that pregnancy which is outside. Medicine means oral tablets like misoprostol. We will not give. We will, because it will do more harm. So so this is so right today it is an uncertain information which I am giving you, and that everything the management we will decide. We'll discuss again after you come back with the second hormone report. Then we will discuss about, depending upon this thing we will discuss. So then we'll treat according to the condition. Now at present, you don't require any treatment. Now, you don't require any treatment. If she has pain, then it's an important thing. You should not ignore it. We have to admit if it is pain. But if she's not having any pain, ignore it. Now you don't require any treatment. Let me tell you. Then one more thing I want to tell you, because you said it is an unplanned pregnancy, and after the pregnancy is ended, after then we will refer you to the contraception clinic for advice, for contraception advice. Then you can use all the type of contraceptives if you have time. If you can say you can use all the type of contraceptives, but suppose the patient station says that she has migraine or something medical condition where contraception is estrogen progesterone contraindicated, sometimes the examiner will give you then something like migraine, then you say you can take all type of contraception except estrogen containing. Sometimes epileptic drugs, she'll be on epileptic drugs, there also you should be careful. So now do you have any other concern, any other doubts? She said, no doctor. Okay, now I'll give you, now you're closing the station. So after checking that she doesn't have any concern, then say you can and I shall give you a 24-hour contact number. Then anytime you develop any bleeding, excessive bleeding or severe giddiness, severe shoulder pain or severe tummy pain, then you immediately come to the emergency. So then that is red flag sign symptoms. Then second thing, that is about 24-hour you have given. I will document whatever we have discussed. I'll give an information patient leaflet that about what we have discussed. That means about pregnancy of unknown location, and we will see you after the blood report, blood pregnancy hormone report, and then I'll inform my consultant. Always keep the consultant in loop. I'll inform my consultant and I'll give an appointment with him. So thank you for your time. So this way the discussion goes with the pregnancy of unknown location. So am I clear so far? So this is, I took some time because I want to tell you how to present. So I don't want to present in 10 minutes and fatafat finish off. I want to say how to present. Then you practice. You always practice and then present to the, you can present to the other mentor. Dr. Padma, you can present. So she will give you the feedback. She will see your presentation and she will say what you have missed and what you have to, we are supposed to say, and what unnecessary things you should not say, what necessary things you should say. So this is the end of the first station. Next we move on to the second station, that is anencephaly. Shall we move on to the second station, Dr. Hira? So first station is over, early pregnancy. So we will be discussing one case from each module. So next move on to the second case, anencephaly. So Dr. Hira, shall I continue? Hello everyone, shall I continue? Hello, can I move on to the second station? Are you able to hear me?
Yes, Dr. Manju, we can hear you.
Yeah, okay then. Nabira, are you there?
Yes, I'm
Nabira,
here.
please project the second slide, second case.
Okay, wait.
Yes, that is the second. This is the second case. It is an abnormal pregnancy. It is an abnormal pregnancy. This is also simulated, patient simulated task. It is a simulated task. There can be any abnormality. Any abnormality can come in the station. For example, anencephaly, spina bifida, echogenic bowel, and echogenic bowel can come talipus. These are the common things. Diaphragmatic hernia. So these are the common things which they come. Always read the patient information leaflets. Please read. Now, this scenario is like this. So, you are an ST5 in the antenatal clinic. In the antenatal clinic, you are about to see Mrs. Rita Evans, 28-year-old, at 18 weeks of gestation, and she has done a scan today, and she came to here to meet your consultant. So this is important. She came to see the consultant. Then, but consultant is not there, and she want to discuss the scan report with the consultant. And then, so scan report will be given. Next slide, please. So the scan report will be given. So this is the scan report. So her name always then be given on the top of the scan report. Name, age, and NHS number will be given on the top of the scan report. Any report they will give in the exam. So it shows a single live fetus with femoral length 75. It's compatible with the 18 weeks 18 plus 6 gestation. So she's 18, and that's corresponding to her LMP. And also it shows posterior skull bone is not seen. Posterior herniation of the posterior brain is present. There is normal amount of fluid around the baby, and placenta is fundal, normal fluid, and the placenta is fundal. So absence of cranial vault and skull bones not seen, suggestive of anencephaly. So they have given the report. So so next slide, please. So then this is the case scenario. Now you know it is an anencephaly. So these are the things. They won't give fetal sex. So the next slide, please. No other abnormalities. So now, what is your task? You have to explain the scan findings to the patient, and you have to give the patient enough information gathering, and see whether she knows about this condition, how much idea she has, address her concerns, because anencephaly every woman will be very worried, and give her address a concern, give the management plan. Okay, now I'm going to start this case. So these are the important things you should think, we should keep in your mind what you have to do in the station. What is not asked, don't do. These are the 4 important lines you have to always remember. So now you say, this is the breaking bad news station. Anencephaly is a breaking bad news. So it is very important. So now what you have to do, see, in this case, in any anencephaly or any breaking bad news stations, or for that matter, any breaking bad news, don't say nice to meet you, nice to meet you, or congratulations. So mechanically we say, without thinking we will say. So don't say a nice to meet you, or smiling face, or like that, don't do. And also I say, I understand that word you should not use. And then so like that, don't use such things, and keep a neutral face. Don't put a smiling face, keep a neutral face, because whatever the patient is at mood, you have to be into that mood. Don't be excessive, either above her moods or below her moods. Be in par with her mood. So here now, what how to tell address the station. I'm telling you. Hello, I'm doctor from antenatal clinic, that is given in the top of the station. Antenatal clinic, may I confirm your name and age, please? Slowly, huh? Don't be excited. So I'm Mrs. Rita Evans, doctor. How may I address you? You can call me Rita. So I can see Rita, that you're pregnant at 18 weeks, and you have come to discuss your scan report with my consultant. Am I correct? Yes, doctor. I'm sorry. I'm sorry. First, then you say, I'm sorry because consultant is not there. I'm sorry to tell you that my consultant is not available today. Any case, if they say consultant is not available, say, I'm sorry, my consultant is not available today. Would you like to continue consultation with me? Or shall I reschedule the appointment? Then she will say, no, doctor, I'll continue. Because it is a examination. In the examination, they will say, role player will say, you continue. They will not say no. So, now, but you are supposed to ask, that, can I continue consultation? Would you like to continue consultation with me? Now, agenda. What is agenda? I can see that you have concerns. I can see that you have done a scan today, and you have some concerns about the report. Do you have any idea about it? Did the scan doctor tell you what is the finding? You have to know whether she understood or not. She knows the condition. So you have to ask, do you have any idea about the scan? Not only in this case, in any case, any investigation, you should ask, she has any idea or not. No. Okay, she will say, yes, doctor. She will be in a low mood. Then, see, I will see, I mean, address all your concerns. So Rita, I'll address all your concerns. But can I ask a few questions to know more about you, so that we can make a management plan? So then she will say, yes, doctor. Sometimes you have to say information gathering first and then BBN. Then I will say the other way also after this case. After this. So then you say, okay, can you tell me more about you? This pregnancy, because she didn't come with any complaints. No, she didn't come with discharge, bleeding, this. So she just came with the scan report. Then say, can you tell me about this pregnancy? Is it your first pregnancy? Same questions. Is it your first pregnancy? She will say yes or no. Planned pregnancy? I told you, explained to you previous station. Planned pregnancy? Yes or whatever she says, according to that you ask. Then, if it is planned pregnancy, how is the pregnancy so far? Have you done your booking blood test? Have you done your dating scan? Important thing is folic acid. Have you taken your folic acid in first 3 months? Every case you have to ask folic acid. If it's a planned pregnancy. So, have you taken folic acid? So, then you ask the dose. Sometimes they may have to take 5 milligram depending upon the situation. Sometimes diabetics or people who have more tendency to develop neural tube defects, they need to take 5. So that you know. And that is obesity and epileptic drugs. So you have to ask the dose. So if it is a planned pregnancy, how is the pregnancy so far? Are you taking folic acid? Have you taken? Because now she's 18. Have you taken folic acid? And how was your blood? Have you done your booking blood test? And have you done the dating scan? Because we want to know whether it's corresponding or not. Corresponding to the dates. Now, previous pregnancy. If she has previous pregnancy, ask about the previous pregnancies. I told you already. If she had termination of pregnancy, ask about the gestation age, what age she got termination, and also or miscarriage. If she undergone termination or miscarriage, both you have to ask gestation age, scan findings, and then mode of treatment, recovery. Then after that, if it is unplanned pregnancy, whether she has, suppose she says unplanned, you ask about the same thing, contraception, has she used contraception, to know whether it's a contraception failure. Then that's previous pregnancies are over now. Now medical. Specifically you need to ask why, because it is an anencephaly, neural tube defect. Do you have any increased sugars? You can say increased sugar, that means diabetes. Do you take any or you can say, do you have any increased sugars or any fits? Because epileptic drugs, they can cause neural tube defects. So you have taken targeted questioning. So do you have any fits or taking any, then BMI, we know from the history only whether it's a high BMI or low. So do you have any increased sugars, any fits? Are you taking any other medication other than for this? And then allergies, any allergies? Then what is okay, just do you know your blood group? Blood group is not blood group is important. Why? Because she may have to go for termination. That's why blood group. And RH typing, reservation, surgery. Have you undergone any surgery in the past? Just one word, because it's not very important. Family history of similar, any abnormal babies in the family, anencephaly, abnormal baby. Family history of any abnormal babies, any genetic problems in the family, any genetic problems in the family. Now, coming to the this is family history, so personal history. Now, do you smoke? Smoking and alcohol are very important in early pregnancy. It can affect the baby. So, do you smoke and take alcohol? If she smokes, how many cigarettes per day? And alcohol, what is the quantity? Which I told you. Drugs may not cause much problem, abnormalities. It's not proven. It's not much research. So just casually you can ask drugs, but special important smoking and alcohol. And so then other thing is what BMI, if it's not given, you ask her BMI. BMI is important. I told you obesity, they will have neural tube defects. More chance. Then how is the support at home? Because this is an abnormal baby. If she undergoes a termination, she'll be mentally very upset. She needs support from home. And if it's an abnormal, so that is why you ask specifically support. And if she knows the report, if she knows, yes, doctor, I know. Do you need any, shall I arrange some counseling for you? Any counseling? Okay. Now, would you like to add anything? Finished. Information is over. Would you like to add anything? So now this is the information gathering. It is one way of starting the station in the abnormal baby. Now, after this, now no need of examination. No need of examination. Going to the applied clinical discussion with the patient. That is applied clinical knowledge. See now, Rita, she knows or doesn't know. Already you asked her whether she knows or not. So it is a breaking bad news station. Even if she knows, or if she knows, then fine. Mostly they don't know. Then in that case, if she knows, no need of BBN. So she says, I don't know, doctor. You say, now Rita, I can see there are two shots, short one and short two. Short one, warning shot. I can see that you have come alone here today. Reduce your voice. Do you want me to call someone to have someone to be with you? Why, doctor? What happened? She doesn't know. I have lot of information to give you, Rita. Short one. This is short one for BBN. Then you say, no, doctor, I don't have anyone. Please tell me what is happening, doctor. Then you say, now you're going to say the warning shot two. See, I have seen your scan report. I confirm name, age, and your NHS number, and it belongs to you. I'm sorry to say, slowly, I'm sorry to say that I do not have a good news for you. So that means I'm sorry to say that the part of the baby, now you explain, be frank, don't hide things or this and that. Now, I'm sorry to say that the scan report says that a part of the baby's skull bone has not developed, which had led to the damage to the baby's brain and spinal cord because it is exposed to the fluid around it. This condition, in medical terms, we call it as anencephaly. It is a life-limiting condition. These babies will not survive. These babies will not survive. Usually, they die before birth or immediately after birth. I am very sorry to give you such a difficult information. Just silence. She may break down. She cries, and then you say, take this, some tissues. If it is there on the table, you say offer. If it's not there also, you just say, have some tissue and have some water, glass of water, even if it's not there on the table also. Then you can say, I wish I had better news for you. Then, but don't prolong it too much because time limit. Do you want to continue our consultation today? Because she may want to come again. Huh? Or and shall I reschedule her appointment? She says, no, doctor. You tell me what you are going to do now. Now, what are you going to do for me? So, like this. Then you say, okay, let me explain to you how to manage your problem. There are you can now. What are your thoughts about it? Now that I discussed with you that this baby is having this problem, what are your plans about it? What are your thoughts about it? Then she will say, I don't want this baby or I want this baby, whatever she says. Huh? Then that will, so whatever, when you would like to continue a pregnancy or you want to end up the pregnancy. And whatever you decide, we will respect your decision. So, what are your thoughts about it? Then she will say, Doctor, I want to continue. Whatever she says in the station, discuss about that option. Don't, suppose she wants to continue, I'm telling you how to manage this. If she wants to do termination, then I will tell you how to. So in the exam, only say one thing only, but you give the options. Now, she says, Doctor, I want to continue this pregnancy. Even after knowing also, she says, then, okay, I will arrange. I see. I will arrange your. I will let me explain to your pregnancy plan. So your case is a high risk pregnancy. Rita, your case is a high risk pregnancy, and it is managed by a team of doctors. You will be under consultant led care. Our consultant will manage. You will be under consultant care with a team of doctors taking care of you. Our consultant. That means you have to tell the team of doctors' names. That is multidisciplinary team. It's very important. So our consultant, our consultant, a genetic doctor, our fetal medicine specialist, because they do frequent scans, and senior midwife. That much. And we need to, you need to come. You need to have more frequent visits, additional scans. We need to do more. You need to come. You need to come for more additional visits and frequent scans. Additional scan. So, but let me explain to you about this pregnancy. There can be some issues during pregnancy. Can I explain to you? Always take her permission. Can I explain to you what can happen with this baby? Yes, doctor. Then she says, for the mother, let me tell you, for the mother and for the baby, for the mother, because there is a more fluid around the baby than normal in this condition, then the tummy will become more bigger and that will cause you some breathing problems, some shortness of breath. So that is breathlessness. That can happen for mother. And then during labor, this is during pregnancy. During labor, let me tell you, there can be some, it may not start. The labor, you may not set into labor. Labor pain may not start by yourself because baby's master gland, which is in the brain, is absent. Brain is absent. So the master gland is not there. So that means it will start the labor normally. Because it's not there, labor will not start. So we may have to give some medicine to kickstart the labor with medicine. That is called induction of labor. So this can be the other issue which can come. The third issue which can come is this type of pregnancy, labor, that once you are into labor, it may not progress properly. It may not progress properly and it will take long time for you to deliver because this baby's head cannot exert enough pressure on the neck of the womb to open it up. So it will take time. It will be prolonged pregnancy. The other thing which can happen is the cord, because the cord can slip out. The membranes can rupture, and the water can leak, the membranes can rupture, and the cord can slip out and come out. So then we may have to do emergency cesarean section. Then or sometimes if it is fully dilated, then if it opens up, we may have to do operative delivery. So this will be more, the chance of cesarean section doing operation will be more. Then sometimes what happens, baby shoulder can get stuck. Baby shoulder can get stuck. So, and the other thing which can happen is after the bleeding, after the delivery, there can be excessive bleeding. But let me tell you, we will have medicines to control it. So these are the issues that can come to the mother. And for the baby, I already explained to you, it can die before or immediately after birth. And whatever whatever we do for the baby, it will not survive. So baby will not be resuscitated. But however, we will give comfort care. These are the words you should remember. Life limiting. One is life limiting condition. It will not be resuscitated, and comfort care will be given. Comfort care will be given. So am I clear? Am I clear, Rita? So this way, you have to tell her about the management. So now, then she will say, then if suppose she want to go for, this is about the continuation of pregnancy. Suppose she want to go for termination of pregnancy. No, doctor, don't want this pregnancy. Then you say termination. Don't say termination without asking. If she doesn't ask. Now, about the termination of pregnancy, when she says, I want this pregnancy to end up, then you say, okay, whatever decision you take, we'll respect it. It is, I know it is a hard decision for you. Ending this pregnancy can be done at any stage of pregnancy as per the abortion law in UK, because for this type of babies we can do anytime. Then let me explain to you. Shall I explain to you the methods to end up the pregnancy? One, yes, doctor. Then you say, maybe offer medication, like we give the tablets which were applied from like pessaries. Then these will block the pregnancy hormone, and then they will start the labor. They'll kickstart the labor. It's like mini labor, and the whole pregnancy comes out. So this is about the medical management. Coming to the, sometimes it may work out. If it works, that is fine. But if it doesn't work, sometimes we may have to go for operation. We will remove the pregnancy tissue from down below with a small operation. Then this is the second method. Now after removing, after the baby delivers, then we can discuss about examining the baby. The need to examine the baby. That means postmortem. So this way, this is the way how to end up the pregnancy. So do you have any doubts? You can take your time. You can you need not because this is not emergency. You can need not decide now. You can discuss with your partner and family members and get back to us. So I will document whatever we have written, whatever we have discussed. Already you have asked any more doubts. Then I will document whatever we have discussed. I'll give an information leaflet about this condition. Let's listen carefully. And also I'll inform my consultant. I'll give an appointment with him. Your next visit will be with him. Then support group is very important. Now I'll connect you to the support group, because this is a mentally disturbing condition. If she talks to the other people who has similar condition, she'll be little at peace. That means some support, moral support. So that is Shine group, Shine charity. Suppose you remember, you can say that. If you don't remember, don't say. Support group. There are some groups which are specific for some things. So then we will refer you to the genetic counseling later on. So now she will then next after that, the future pregnancies. What happened, doctor, if you have to say about the future pregnancies? She can ask also, what happened to the next pregnancy if I plan, doctor? Will the same thing happens? She may ask you, or you yourself say. So let me tell you, Rita, if you're planning future pregnancies, this condition can occur again. 98% they will be healthy babies. Always say nice things first. 98% out of 100, 98 out of 100 babies will be healthy. But 2 out of 100 can have similar condition. That is recurrence. That is one thing. Second thing, you need to take folic acid when you plan pregnancy. Before you can become pregnant, you start taking folic acid and continue up to 3 months. and you need to take higher dose. Take it for 3 months after pregnancy confirms. Then, because what research has shown that the folic acid levels, if they are low in the blood, the chance of having abnormalities in the brain and spinal cord are more. So that's all. So now, anything else would you like to ask? Already asked. Thank you for your time. So this way, any abnormal baby, if it is talipus, the treatment is different, but you can discussion will be same. Then other spina bifida, you can say you can get what I told you. So the other way of presenting this case is first you take the introduction, then after that I told you information gathering, then BBN. But the other way you can say first BBN, first you break the bad news, then with the short one and warning shot one, warning shot two, then you can go for information gathering. But then she starts crying this and that, so it will you will get unnecessary tense. So go with the information gathering first, then break the bad news. That is a better, I feel. So this way we manage this this type of case, abnormal case. So today we have discussed 2 cases, and tomorrow also I am going to discuss 2 cases from other modules. One is tomorrow diabetes from maternal medicine, and tomorrow I'll be discussing one more case, postpartum problem, pulmonary embolism, and day after tomorrow, that's on Saturday, 2 more cases. So these 3 days you can listen to our the way of teaching, and then you can decide. So this way I tell you to present. If I ask you to present, you don't know what is the patient safety point, what to ask, what not to ask, and taking the feedback and all those things. I'm not I myself faced. Out of experience, I'm telling you the hardships which I went through. So I thought this is the best way, teach you how to present. You will present the same cases or different cases to Dr. Padma. She's our mentor. So then she will present, you present, but you have to limit your presentation to 10 minutes. I am telling you, explaining to you, that's a different thing. But you have to present, because I want you to understand basic thing and what to tell, what not to tell. Then you have to present in 10 minutes. So you can take around 4 minutes for information gathering, average 4 minutes for information gathering from introduction, then 1 minute, 1.5 minute to explain the investigations, any investigation, blood and scan and everything. Then the remaining 5.5 minutes, and then so 4 plus 1, 500 minutes, 5.5 are over. Then you'll have 4.5 minutes. So 4 minutes you explain the situation to her. Then half minute closure. You can say fatafat 4. I will document whatever we have discussed. I'll inform my consultant, give an appointment with my consultant. This is the patient information leaflet. I'll connect you to the support group. I'll write back to GP. So how much time you will take? So this way, 4 minutes first information gathering, 4 minutes explanation to the patient. Okay. So today these 2 cases are over. Tomorrow we will meet at same time, 7 o'clock, 7 UAE time, and they will post our Dr. Hira, MedHOME, they will post the details in the group tomorrow. So am I clear so far? Hello, Dr. Hira.